Welcome to the deep dive. All right, today we're rolling up our sleeves and tackling a specific subject, bladder cancer. We've got a set of detailed notes here, and our mission is to really dig in, pull out the most crucial information, and package it up so it's high yield and easy to grasp, especially if you're prepping for something like the MSRA or just want a solid understanding.
Absolutely. Think of this deep dive as your accelerated path to being well-informed on the topic. We're going to go through the material section by section, extracting those key nuggets you absolutely need to know, cutting through any potential clutter in the notes.
So whether you're revising or just genuinely curious about bladder cancer, you're in the right place. Let's jump in. Okay, first things first. When we look at the definition provided in our notes, what exactly is bladder cancer at its core?
Essentially, we're talking about abnormal cells starting to grow uncontrollably in the lining of the bladder. The sources are clear about the main distinction. Non-invasive, meaning the growth stays contained within that initial inner layer, and invasive, where it pushes deeper into the bladder wall.
Got it. So contained versus pushing through. And the notes also break it down into different types, right?
That's right. The vast majority, what you'll see most often, according to the material, is transitional cell carcinoma. But the notes also mention squamous cell carcinoma and adenocarcinoma as other less common types.
Okay, so that's the what. Now let's talk about the why. Why does this happen? What did the sources highlight as the main drivers or risk factors? This is where it gets particularly important for understanding prevention and who might be most affected.
Well, the notes point to a combination of factors, both things you inherit genetically and things you're exposed to in your environment. If you're looking for the single biggest takeaway risk factor from this material, it's unequivocally tobacco smoking. Huge link.
Smoking makes sense. What about things people might encounter through their work?
That's another major one highlighted in the sources. Occupational exposure to certain chemicals. We're talking things like dyes, rubber, some textile chemicals, that kind of thing. This underscores just how much external factors can influence risk.
So smoking beyond certain jobs are high on the list. What else did the notes flag?
Age and gender are significant. The risk definitely goes up as you get older, particularly over 65, according to the notes, and it's noticeably more common in men. Also, chronic inflammation in the bladder, perhaps from long-term infections or bladder stones, that can also increase risk.
Right.
And certain medical treatments come up too, prior radiation therapy to the pelvic area and a specific chemotherapy drug, cyclophosphamide. And yeah, there's a genetic link, including family history and conditions like Lynch syndrome.
I noticed something else a bit less common. Listed specific infections,
Oh.
like HPV-16 and schistosoma hematobium. That seems, well, surprising maybe.
It is, yeah. The notes specifically tie schistosoma hematobium infection, which is a parasitic worm, to an increased risk of squamous cell carcinoma of the bladder. That's particularly in certain geographic areas, you know. And HPV-16 is mentioned as a potential additional factor, though maybe less prominent than smoking or chemical exposure. So while less frequent in some populations, they are flagged in the source material as relevant risk factors.
Fascinating how diverse the potential causes are. Now, let's move from the causes to how the cancer actually develops. What's the basic process described in the notes, the pathophysiology?
The mechanism outlined is essentially uncontrolled cell division, right there in the bladder lining cells. This is driven by accumulating genetic mutations and disruptions in the cellular pathways that normally keep growth in check.
And if it becomes invasive, as you mentioned earlier, how does that change things?
Well, if the cancer becomes invasive, the notes explain it means the tumor cells are pushing through those initial layers into the muscle wall and beyond. This significantly increases the risk of local spread within the pelvis and, critically, metastasis, the cancer cells breaking away and traveling, through the bloodstream or lymphatic system to form tumors in distant organs.
Speaking of how common it is, the notes provided some specific UK statistics. Let's look at the epidemiology. What picture do those numbers paint for us?
Looking at the data from the sources, particularly the UK context, bladder cancer is the 10th most common cancer overall. We're talking about roughly 10,200 to 10,300 new diagnoses every year. It's actually the most frequent type of tumor found within the entire urinary system.
Wow, the most frequent in the urinary system.
Yeah, and makes up about 3% of all new cancer cases in the UK.
And what about the impact in terms of mortality?
The notes provide figures showing around 5,485 deaths annually. based on 2016-2018 data. So significant impact.
The age and gender points show up in the epidemiology data too, don't they?
Yes, they do. The statistics reinforce that it's predominantly a disease of older age, with the majority of cases occurring in people over 75. And men have a much higher incidence rate than women.
Right.
Interestingly, the sources also note that despite lower incidence, women often face a poorer prognosis compared to men, which is an important detail.
That is interesting.
And unsurprisingly, smoking is reiterated as a major contributing factor in the UK numbers as well.
So, knowing who is at risk and the prevalence, what are the signs that might make someone suspect bladder cancer? What are the key clinical features described in the notes that you absolutely must look out for?
The single most common, and often the first symptom mentioned, is hematuria, that's blood in the urine.
Is that always something you can see? Like visible blood?
The notes are very clear on this. Painless gross hematuria, meaning visible blood that doesn't hurt, is present in 80–90% of cases and is a major red flag. But it's crucial to know that even microscopic, non-visible hematuria, especially in someone over 60, should trigger investigation because the sources link it to a significant risk.
Okay, so even if you can't see it.
Exactly. The absolute key takeaway here is that any painless gross hematuria requires urgent investigation until you've ruled out bladder cancer. Really important point.
That's a really important distinction, visible or non-visible blood needing attention. What about other symptoms related to urination?
Yes. The notes list what we call irritative voiding symptoms. These include dysuria, which is painful urination, increased urinary frequency, and urgency, feeling like you have to go right now.
Can the pain be outside of the act of urinating itself?
It can, yeah. The notes mention that pelvic, suprapubic, that's above the pubic bone, perineal, or rectal pain can occur, particularly as the disease progresses. In some cases, especially with larger tumors, a doctor might even be able to feel a palpable mass above the pubic bone.
Right. And what signs might indicate the cancer is more advanced, perhaps spreading?
When the cancer is advanced, the sources list symptoms related to things like kidney blockage that can lead to uremic symptoms from kidney dysfunction. And if it's metastasized, symptoms will depend on where it's spread, things like bone pain, shortness of breath if in the lungs, right upper quadrant pain or jaundice if in the liver, or enlarged lymph nodes.
Okay.
General constitutional symptoms like unexplained weight loss, significant fatigue, and loss of appetite are also mentioned, those sort of non-specific signs.
I saw the notes also mentioned voiding symptoms again in advanced stages and that there might be gender differences in presentation.
That's right. Voiding symptoms can become more pronounced in later stages, or with carcinoma in situ, CIS, which is that flat, high-grade form of cancer within the lining. The sources also note that women are unfortunately more likely to be diagnosed when they already have muscle-invasive disease.
Oh, really?
Yeah. And while most patients are diagnosed at an earlier stage, about 5% of patients already have metastatic disease at diagnosis, most commonly in the lymph nodes, lungs, liver, bone, and the central nervous system.
So you have someone coming in with some of these symptoms, especially hematuria. Before you land on a diagnosis of bladder cancer, what other conditions do the notes suggest you should consider? What's the differential diagnosis?
Good question. The sources provide a list of things that can look similar symptomatically.
Oh, you don't want to jump to conclusions.
Exactly. It's important to think about other potential causes for blood in the urine or urinary symptoms. The notes list conditions like hemorrhagic cystitis, which is inflammation causing bleeding, kidney stones or nephrolithiasis, kidney cancer or renal cancer, trauma to the urethra, and straightforward urinary tract infections. These are crucial to rule out.
All right, so you have a suspicion based on symptoms and risk factors. How do you actually investigate and confirm a diagnosis of bladder cancer based on the information provided? What are the key tests?
Okay, the notes start with some basic initial tests. A urinalysis is important to check for infection, which could explain symptoms. A full blood count can look for things like anemia from chronic blood loss. Renal function tests and a coagulation profile are also standard initial steps.
And when you need to really visualize what's happening or get a tissue sample, that's the next step.
This is where the crucial diagnostic tools come in, particularly for patients over 35 with visible or non-visible hematuria. The notes highlight CT urography, which is a type of CT scan looking at the entire urinary tract, and cystoscopy.
Cystoscopy, okay.
Yeah, cystoscopy is where a thin camera is inserted into the bladder to visualize the lining directly. Imaging might show thickening of the bladder wall, blockage causing hydronephrosis, that kidney swelling, or visible tumors.
And how is the diagnosis actually confirmed? Is it just the pictures?
No, diagnosis absolutely relies on that cystoscopy, taking biopsies of any suspicious areas seen, and urine cytology, looking at urine under a microscope for cancer cells. The notes point out that urine cytology is particularly valuable for diagnosing and monitoring that flat, high-grade CIS, as it has high sensitivity and specificity for those kinds of cells.
Right, that specific flat type you mentioned earlier.
Exactly, because the cells shed more easily into the urine.
Gotcha. The sources also mention investigations for staging after a diagnosis is made, to see how far it's spread.
Yes, once bladder cancer is confirmed, especially if it's potentially invasive, you need to figure out how far it's spread. That's staging. Staging investigations listed include chest x-ray, CT scan of the abdomen and pelvis, checking alkaline phosphatase levels, ALP, and doing a bone scan to look for bone involvement, and liver function tests for liver spread.
A whole battery of tests, then.
Pretty much. More detailed T-staging might use MRI or CT with contrast. A CT of the chest, abdomen, and pelvis is explicitly recommended for confirmed muscle-invasive disease. And sometimes a biopsy of the prostatic urethra is necessary, particularly with suspected bladder CIS, or if that area looks abnormal during cystoscopy.
And there are specific UK guidelines mentioned for when to refer patients. Nice guidelines.
Yes, the NICE referral guidelines are detailed in the notes and are really important for timely diagnosis. Can't stress that enough. Urgent referral is needed for anyone aged 45 or over with unexplained visible hematuria or visible hematuria that comes back after treating a UTI.
Okay, 45 plus visible blood, urgent.
Right. Also urgent for those aged 60 and over who have unexplained non-visible hematuria plus either painful urination, dysuria, or a high white cell count on a blood test.
60 plus non-visible blood with other symptoms.
Exactly. And a non-urgent referral is appropriate for people aged 60 or over with recurrent or persistent unexplained UTIs. Knowing these criteria is key for practice.
Definitely good to know those triggers.
Building on the diagnosis and investigations, the notes provide the T&M staging system. This is absolutely fundamental for understanding the extent of the cancer and guiding treatment.
Okay, let's break down T, N, and M as described in the material. What does the T stage tell us?
T stands for tumor, and it describes how deeply the primary tumor has invaded the bladder wall. The stages start very superficially. T is non-invasive papillary cancer, meaning it grows outwards in finger-like projections, and T's is carcinoma in situ, CIS, which is that flat, high-grade cancer confined to the very inner lining.
Okay, T and T's are superficial.
Then T1 means it's invaded the subepithelial connective tissue, the layer just below the lining. T2 means it's invaded the muscularis propria. The muscle layer T2A is superficial muscle, T2B is deep muscle.
T2 is a muscle layer, got it.
T3 means it's gone through the muscle into the paravesical tissue, the fat surrounding the bladder. T3A is microscopic invasion. T3B is macroscopic, meaning it's a visible extravesical mass. And T4 is invasion into adjacent organs. T4A involves the prostate, uterus, or vagina, and T4B involves the pelvic or abdominal wall.
Wow. What?
Understanding the T stage is critical because it separates non-muscle invasive T1 from muscle invasive disease, T2 and above, which drives management. Big difference.
Right. That distinction between T1 and T2 is a major shift in management. N covers lymph nodes.
Correct. N is for nodes, specifically regional lymph nodes. N next means the nodes haven't been assessed. NS means there's no regional lymph node metastasis detected. N1 means there's metastasis in a single lymph node in the true pelvis. N2 is metastasis in multiple lymph nodes in the true pelvis, and N3 is metastasis in common iliac lymph nodes, which are a bit further up.
Okay, N0 is clear, and 1, 2, 3, increasing involvement, and finally M for distant metastasis.
Yes, M is for metastasis at a distant site. MX means distant metastasis hasn't been assessed. N0 means there is no distant metastasis. And M1 means distant metastasis is present. Putting T, N, and M together gives the overall stage group, which, as the notes emphasize, is the roadmap for deciding treatment and predicting outcomes.
So, diagnosis is made, staging is done. How is bladder cancer managed based on the treatment strategies outlined in the source material? It sounds like it varies a lot.
Oh, definitely. The notes really highlight that management in the UK is complex and highly personalized. It depends fundamentally on the stage and grade of the cancer, its location, and importantly, the patient's overall health and fitness.
Let's start with that non-muscle invasive cancer, the TA, TATS, and T1 stages. What's the initial approach there?
For non-muscle invasive bladder cancer, treatment is stratified by risk low, intermediate, or high risk of recurrence and progression. The initial and crucial step is a complete transurethral resection, TUR, of the tumor. This is done via cystoscopy, using an instrument to cut out the tumor from inside the bladder. The goal is complete removal.
Okay, TUR first.
Yeah. The notes mention a second TUR might be needed, especially for T1 tumors, if the first resection wasn't considered complete or if it's high grade.
And after the TUR, what kind of additional treatments are used inside the bladder? Intravesical therapy.
Exactly. This is where intravesical therapy comes in administering drugs directly into the bladder. For lower risk, it might be a single dose of chemotherapy like mitomycin C right after the TUR. For intermediate and high-risk disease, the notes discuss courses of either chemotherapy, often mitomycin C, or immunotherapy with BCG, Bacillus calmette-guerin.
BCG.
BCG is often used for high-risk T1 and CIS because it's particularly effective against those types, though the notes don't delve deeply into the mechanisms here, just the agents used. Now, shifting gears dramatically, what about muscle-invasive bladder cancer T2 and above? The management changes significantly, right?
It does. The notes indicate a much more aggressive approach is needed here because of the risk of spread. It sounds much more serious.
Exactly. For patients who are fit enough, neoadjuvant chemotherapy, that's chemotherapy given before surgery with a cisplatin-based combination, is recommended for muscle-invasive tumors. The goal is to shrink the tumor and treat any microscopic spread before the main procedure.
And the main procedure is usually radical surgery, removing the bladder.
Yes, radical cystectomy. The notes describe this as the preferred curative treatment for localized invasive disease. This surgery involves removing the entire bladder, along with the prostate or uterus vagina, and a pelvic lymph node dissection to check for nodal spread. It's major surgery.
Wow. What options are there for diverting urine after the bladder is removed?
Well, the notes mention that for eligible patients, an orthotopic bladder substitute can be created using a piece of intestine, which is connected to the urethra, allowing for more natural voiding.
Okay, sort of new bladder.
Kind of, yeah. Other options exist, like an ileal conduit leading to a stoma bag, but this specific one is mentioned as being offered to eligible patients in the notes. Adjuvant chemotherapy, chemo, given after surgery with the cisplatin combination might also be considered in specific high-risk cases after radical cystectomy.
Are there alternatives to such major surgery? Like radiotherapy?
Yes, radical radiotherapy with concurrent radiosensitizers is listed as an alternative treatment option, sometimes preferred for patients who aren't suitable for surgery or prefer to avoid it. And for locally advanced tumors that can't be surgically removed curatively, palliative cystectomy removal of the bladder just to relieve symptoms like bleeding or pain can be performed.
What about when the cancer has already spread to distant sites, metastatic disease? What are the options then?
For metastatic bladder cancer, the treatment shifts to controlling the disease and managing symptoms. The notes describe different approaches based on the patient's fitness level. Patients considered fit enough typically receive cisplatin-containing combination chemotherapy regimens.
Cisplatin again, okay.
Yeah, it's a key drug.
Yeah.
For those deemed unfit for cisplatin, maybe due to kidney function or other health issues, carboplatin-based combination chemotherapy or single-agent chemotherapy are options, with gemcitabine carboplatin being a preferred regimen listed. If the cancer progresses after platinum-based chemo, second-line treatment options are considered, though the notes don't detail specific regimens here beyond mentioning they exist.
The notes also touched on some newer treatments, didn't they? Immunotherapies.
They did. Avelumab is specifically recommended as a maintenance therapy after platinum-based chemotherapy for locally advanced or metastatic urothelial cancer that hasn't progressed. Kind of keeps things stable for longer. And nivolumab, another immunotherapy, is mentioned for adjuvant treatment, meaning after surgery, in high-risk cases of muscle-invasive urothelial cancer to try and prevent recurrence. These represent important advances.
So more tools in the toolbox now. Beyond directly treating the cancer, symptom management is a big part of care, isn't it? Especially palliative care.
Absolutely. It's crucial. The notes detail palliative strategies. Palliative radiotherapy can be really effective for managing troublesome bladder symptoms like bleeding, hematuria, painful urination, frequency, or having to get up at night. Nocturia. For severe pain in the flank or kidney injury caused by the tumor blocking the ureter, procedures like a percutaneous nephrostomy, draining the kidney through the back, or a retrograde stent, placing a tube in the ureter from below, can help restore drainage.
Relieving that blockage.
Exactly. Intractable bleeding that doesn't respond to other measures might be managed with hypofractionated radiotherapy, a shorter course of radiation, or embolization, blocking blood vessels supplying the tumor. And pelvic pain, specifically caused by the cancer, can be addressed with palliative radiotherapy, nerve blocks, or palliative chemotherapy. Lots of options for symptom control. Looking at the outcomes described in the notes, the prognosis, what's the most important factor determining how well someone is likely to do?
It seems like everything we've discussed points back to one major driver, right? The stage.
Exactly. The stage and grade of the tumor at diagnosis are the absolute key determinants of prognosis, according to the sources. It really dictates everything.
How does that break down in terms of survival rates? What do the notes say?
For those early-stage, low-grade tumors, TATs, T1, particularly the superficial ones, the outlook is generally favorable. The notes give a 5-year survival rate of 80–90% for these superficial tumors.
That's quite good for early stage.
It is. However, the prognosis gets significantly worse as the stage increases. For muscle-invasive bladder cancer, T2 and above, the 5-year survival drops to a range of 30–60%. Big drop.
Yeah, that's a huge difference.
And sadly, for cancer that has already spread to distant sites, metastatic disease, M1, the prognosis is poor, with the notes citing a 5-year survival of only 10–15%.
That really underscores why catching it early is so critical. The notes also mention an ongoing challenge even after successful treatment, don't they? Recurrence.
Yes, absolutely. Even with early-stage disease, there's a significant ongoing risk of recurrence and potentially developing metastasis later. This necessitates regular follow-up and surveillance strategies after treatment. It's not necessarily a one-and-done thing.
Right. Finally, let's talk about the potential downsides, the complications. What complications are highlighted in the notes, either from the cancer itself or from the treatments?
Okay, the notes list several potential complications. From the cancer itself or related to its presence, common issues include urinary tract infections, difficulty emptying the bladder leading to urinary retention, and hydronephrosis, that swelling of the kidney we mentioned, caused by the tumor blocking the ureter.
You mentioned recurrence being a risk. Is that always in the bladder itself, or can it pop up elsewhere?
That's a good point. The notes specifically mention the risk of tumor recurrence not just in the bladder, but also in the upper urinary tract, the ureters and kidneys, and an increased risk of developing transitional cell carcinoma in the urethra. So surveillance needs to cover the whole urinary system.
So the whole system is at risk.
Potentially, yes. Surgery, particularly the more extensive procedures, can also lead to complications. The notes list potential issues like bowel obstruction, blockage of the ureters, kidney infection, pyelonephritis, and wound infections related to the surgery site. Specifically, radical cystectomy, as you might expect, leads to erectile dysfunction. That's a major quality of life issue. And if that orthotopic bladder substitute is created, there's a risk of urinary incontinence, which also impacts quality of life.
That's a comprehensive list of potential challenges, really highlighting the significant impact of both the disease and the interventions needed to treat it.
It does. The notes also briefly mention that surveillance protocols after treatment are tailored based on the cancer type and the specific treatment received, involving tools like cystoscopy, upper tract imaging, and other assessments to catch any recurrence early.
Wow. Okay. We've really navigated through the key points from these notes on bladder cancer. From understanding what it is, those critical risk factors like smoking and occupational exposure, recognizing the vital symptom of painless gross hematuria, breaking down the staging system, exploring the varied treatment options depending on stage, all the way through prognosis and potential complications.
We aim to pull out the absolute high-yield information that's essential for getting a solid handle on this condition, following the structure of the material provided. Hopefully it's clear.
So taking all this in, what does it really tell us? It underscores profoundly how vital awareness of key symptoms, especially blood in the urine, is for potentially life-saving early detection. And it shows just how tailored and complex management becomes once a diagnosis is made, depending entirely on the stage of the disease. It's not simple.
Not at all. It also leaves us with a thought-provoking question, maybe. Given how significant smoking and occupational exposures are as risk factors, are there opportunities for even greater impact through public health initiatives and workplace safety measures to prevent bladder cancer from ever developing in the first place?
Absolutely. A powerful question to consider. Prevention is always better. If you're using this deep dive for revision, perhaps for exams like the MSRA, we hope this has provided you with a clear and memorable framework. And if you're looking for further resources to support your revision, the notes pointed us towards pathmsra.com and freemsra.com.
Yeah, they offer tools and materials specifically designed to help with your medical revision. Definitely worth checking out.
That's it for this deep dive. Thanks for joining us.